Hello everyone, welcome to the day one of the second healthcare conclave. Today we had an amazing inaugural session. We had experts from across the globe and across the India, and we also had health experts and policymakers from the various state governments and also from the government of India who have come together to discuss and deliberate upon various challenges and various opportunities that this new era of COVID-19 has put forward. And now we are yet before you with yet another esteemed panel who have come together, not completely focused on healthcare, but on the medical education. And this particular session would be focusing on medical education during the pandemic. What are the key learnings? What are the challenges? What are the opportunities? And what would be the way forward? So, my name is Sudhir Gautam. I'm the editor with the APAC News Network. We are thankful to all our partners from the Government of India to be the government partners for this second edition of Global India Healthcare Conclave. We are thankful to Digital India, the Government of India, NIC, National Informatics Center, MyGov, and also HSCC, and various other state governments who have supported us. So, join me in welcoming our esteemed panelists who are dealing with the medical education that directly connects between the healthcare system and also the academia. So join me in welcoming our first speaker, who is from Odisha, Bhubaneswar, Dr. Ashok Kumar Mahapatra, who is a Vice Chancellor for SOA Deemed University from Odisha. Welcome, Professor Mahapatra. Thanks for joining us. The next speaker I would like to call upon is Dr. Raju Yeravdekar, who's the Dean, Faculty of Health Sciences, Symbiosis International, which is the deemed university. Thanks for joining us, Dr. Raju,
Thank you.
for this
Thank you
important
for
session.
inviting me.
Thank you. And next, I would like to call upon our next speaker from the state of Karnataka, Bangalore, Dr. P. Balakrishna Shetty, who is the Vice Chancellor with the Sri Siddhartha University. Thanks for joining us, Dr. Bala.
Thank you.
And yet another special guest we have from the state of Chandigarh, Dr. Preeti Pradhan. She is the Dean, Chitkara School of Health Sciences. Thanks for joining us, Dr. Preeti.
My Preeti.
A very special guest from the UAE, from the Middle East, we have Mr. Arpan Stephen. He is the e-learning expert with the Arabian Gulf University, Bahrain. Thanks for joining us, Arpan. With this, I would like to we have very special perspective put forward, and in the present scenario of COVID-19, the challenges that has been thrown upon the humankind, a lot of learnings are there. So with this, the first question before we move on to our discussion about the medical education, the learnings and key takeaways, my first question would be to Mr. Dr. Rajiv from Symbiosis. I would like to ask him, in this, lot of learnings have come across. Now, you as a dean of this particular prestigious institution, what do you think needs to be incorporated in the medical education? What are the learnings in this new order, Dr. Rajiv?
Yes, at the outset, thanks APAC Global Network for getting together all of us to air our views. Thank you for getting to the table a very relevant, pertinent, and burning question about healthcare. And within the healthcare, we are talking of two components: healthcare service delivery and healthcare education. And within healthcare education, we've got further two components: the medical and nursing education, which is probably governed by regulatory bodies of the INC and the newly constituted or commissioned NMC, and the not so regulated, unorganized and disorganized allied healthcare sector. So, and within medical and nursing, you have further subdivisions of preclinical and clinical. So the dimensions and learnings for COVID are different for the healthcare sector on one part and the medical and nursing on one part. And within the medical and nursing, it's different for preclinical and clinical domains. I'm sure my esteemed colleagues will bail me out on this. Having said this, we also need to understand that Corona has been a game changer and has been a great teacher to that extent. And I would quote Sir Winston Churchill here, who once said very historically that never let a crisis go to waste. And exactly this is what Corona has done. The crisis has made us learn adaptations and adoptions, various forms of which I shall be elaborating subsequently. Also, our founder chancellor, Dr. Muzumdar, always says that besides being a destroyer, Corona has been a great teacher. It has taught us, one and all, the requirements for adopting technology in its varied myriad forms to effect healthcare delivery, whether to telehealth services or imparting medical or nursing or healthcare education through the deployment of various technological aids and gizmos. Never before have the students of medicine been exposed to this once in a lifetime opportunity of facing a public health crisis and the exposure to a fractured public healthcare infrastructure in developing countries exemplified by India. What with the Corona throwing open the exposure to students of what we call as public health strategies, health communication devices, mobile technology, the use of personal protective equipments, the importance of advisories from global authorities, the learning and benchmarking with global practices, and all ingredients and components of a public healthcare delivery system, which unfortunately we as medicos probably never got a chance. Believe you me, at this point of juncture, I would like to stress on the difference of education and training in public health vis-a-vis what we learn in med schools as preventive and social medicine. Though apparently synonymous, the two are diametrically opposite each other in the sense of experiential learning and practical takeaways to emerge as a Indian-based doctor or an Indian practitioner as envisaged way back in the 1950s, Sir Joseph Bohr, when he came up with his seminal report on the Bohr Committee, which still forms the basis of public healthcare delivery in India. Having said this, the Corona has thrown upon us challenges of adopting technology. Now, as I said, the technology from the medical and education, nursing education consists essentially of the deployment of technology, virtual online classrooms. So we have got your favorite Dr. Google, you've got Zoom classrooms, you've got Cisco WebEx, you've got Google Chats, you've got WebEx, and you've got a host of and plethora of online sessions, online chat sessions, web podcasts, pre-recorded, live video recordings, chat rooms, classrooms, blackboards, synchronous and asynchronous learning, virtual classroom attendance, virtual grand round, so on and so forth. But more importantly, in the teaching learning arena comes the all-important challenge of virtual assessment. Given the fact that the safety of staff and students is of paramount importance, it is imperative for us to ensure all norms of patient safety in implementing our models of education. And towards this end, therefore, the assessment strategies, whether they are online MOOCs, they are online MCQs, online virtual OSCE, which the Royal College recently implemented, models which have been propagated by the American Academy, talking of competency-based time variable model, CBTF, the model of defining certain competencies vis-a-vis skill sets which can be evaluated remotely, all these have brought about a significant paradigm shift in not only, as I said, in our teaching learning pedagogies, but also in our assessment strategies. It has also brought to the forefront the lacunae of the existing medical education, wherein we as medicos probably have been trained to work in silos in our own ivory towers. And today, in the 21st century world, where we talk about adaptive agility, synergistic collaborations, transdisciplinarity, deep sense, and handling problems of emotional intelligence, never before have these problems and issues been brought to the forefront. We have students asking us questions pertaining to academics, academic delivery, pertaining to fee payment, and all these are crucial and central to student well-being. And believe you me, as educationists, as healthcare providers, be it the patients or the students, they are core to our business. We are here because of the students or the patients, and it becomes on us to ensure their well-being, not only from academic perspective, but other correlated domains as well, because one aspect of the student's life impacts and collides invariably and affects the performance of students in various disciplines. So, clear cut communication strategies on an ongoing basis, communicating the advisories, the guidelines, the directives received by the various authorities, be it the Ministry of Health and Family Welfare, be it multilateral agencies such as the WHO, be it the Ministry of Education, we are constantly sharing with our all stakeholders. Apprehensions and anxieties run high. Mental health and mental well-being of the students has to be catered to. We need to impress upon them that there would be a fair and a robust system of ensuring their safety, well-being, ensuring that they get their return on investment by way of the time spent, the money incurred, the lack of physical exposure to teaching aids, assessment strategies, notwithstanding, the adoption of best practices, say for example, bubble classrooms or bubble participation as is propagated by the Royal College of Surgeons, the importance and adaptation of innovative strategies, and at the same time, not diluting the rigor of teaching learning as well as the assessment, and finally impressing upon the students that corona is not a passing by phenomenon. It is an uncertain. We don't know when it will pass on, and therefore technologies like applied artificial intelligence, virtual reality, so on and so forth are here for us to stay. And it's in the fitness of things that we become fast learners to produce. Probably all the panelists, with due respect to their age, are on the other side of 50 and probably are not on the thresholds of their careers, and they have the onerous responsibility of generating the new look, new breed of digitally qualified healthcare professionals, be it healthcare delivery or be it educational delivery. So that is in a nutshell. We're trying to strategize overcoming the drawbacks of rote learning as was propagated by the medical education, the lack of a regulatory framework for the allied healthcare, the lack of online remote learning, assessment strategies, and ultimately ensuring the well-being of students or patients, whatever the stakeholder may be. Thank you.
Thank you very much, Dr. Rajiv Yeravdekar from the Symbiosis. Now, I would like to take the perspective of our special speaker from the state of Odisha, Dr. Ashok Kumar. Sir, would you, this particular COVID era has put forward certain perspective, and you, as we were discussing before, what is that standardization of medical education we should look at to deal with such scenarios in the coming days?
Thank you very much. I must thank APAC for organizing this health education conclave. See, first thing we have to see what is the health like before pandemic. If you look at year 1900, there are less than 10 medical colleges. And 2020, there are more than 500 medical colleges, and our registration or number of students going to 80,000. And repeatedly, if you look at the evaluation of medical and engineering graduates, that about 20% of medical graduates or medical schools will get 50% mark. That is by independent. There are four organizations those who rank medical, engineering, management, general colleges. And if you take 50% pass mark for the medical colleges, only 20% will be up to 50% mark. And if you take engineering colleges, then it will be only 10% who will be achieving 50% mark. So that we are producing large number of graduates with a poor infrastructures or lack of trained, qualified doctors who can teach them. Unfortunately, a large number of people do not go on to go for faculty position at medical colleges. They would rather go to corporate and make money rather doing the medical education. Or many states are confronted with the medical faculty doing practice and earning money so that they get enough salary. Instead of getting more salary, they get more money. So the medical education has not been uniform despite of MCI, which has been struggling many years. I was the chairman of postgraduate committee of MCI in the era between 2009 and 2011. That is the time Ved Prakash committee said that we need lot of doctors. I was looking at the health scenario of India before pandemic. We need somewhere about 18 lakhs of doctors, and in last 75 years, we have produced hardly about 7.5 lakh doctors, out of which maybe 1.5 to 2 lakhs either left the country or superannuated, or they passed away because of old age and they have gone. So we have effectively strength of about 6 lakhs doctor, and we need somewhere another 12 lakhs. So we have got situation, we need people, there is no quality education, so we are struggling, and MCI has no choice to give approval, but then disapproval, because the people promise that they will have good medical education, yet after the medical college start, when we inspect, they don't have. We are not talking about AIMS or Symbiosis or high quality institution. We are talking average medical institution. This is one type of doctor. Then second is lack of ethical values. If you had gone to medical science about 30-40 years back, it's a service oriented department, not many or commercial oriented department. But if you have to see why MCI have to insist of the ethical issues, ethical guidelines, the state ethical committee, that because more and more it is realized that doctors may be resorting to unethical practices. So one side there is a deficiency, other side poor quality, third side there is an unethical practice. Now we come to pandemic area. In the pandemic age, our infrastructure has further weakened because we need lot of doctors for managing pandemic. For example, we have 2,200 beds in pandemic in COVID. We have 6 hospitals. 3 hospitals are 500 bedded hospital, and 2 hospitals 200 bedded hospital. And about a month back, when the corona was in the peak, we were not having beds in our 850 bedded hospital Bhubaneswar with 150 bed ICU and 100 ventilators. So the question is that it has weakened the medical system, and non-COVID patients are suffering more. Unfortunately, in this pandemic, we are confronted with two things. The medical professionals are suffering because they are exposed 10 times higher risk. They are mentally and physically are much higher risk, and all over the world they are called that high risk professionals. Okay. On the other hand, there is nobody feels sympathetic. The society rather behave stepfather, stepbrother attitude to the doctors because they are outcasted. If you look at the data in last many Maharashtra, Delhi, and many states, the doctors employed in the COVID hospital do not get money. So it is a very situation where you give services, but there is no money for the salary. So in this scenario, you have to understand, we have to educate the medical people. Medical people, quality medical education, which include skill-based, knowledge-based, society-oriented, and holistic approach to the society. The four pillars of new education policy: quality medical education in a corona affected area. When the specialty, if you look at before pandemic, 30% medical teachers posts are vacant across India. Whether you talk about All India Institute, I work in All India Institute Delhi for 42 years. I was director of Sanjay Gandhi and I was director of AIMS Bhubaneswar. You can understand how difficult to get quality faculty for AIMS. We would rather like to non-fill of the post rather than taking an average student, because AIMS doesn't come under the MCI. We maintain quality, not filling of the professor post who is not fit for that post. But that is not true other medical colleges, because if they do not have a professor, the medical college has the risk of de-recognized. So one side you are going to be de-recognized, other side you have to have a substandard person who has to deliver the education. And MCI say that only 6 papers are required to become a professor. When I joined as assistant professor at AIMS New Delhi, I had 25 papers. Many of our professors have 200, 300, 600 papers. Then also they are not sure they will get to a professor post. So you are talking about high quality medical education, average quality medical education, and poor quality medical education, even though you have a regulatory authority. A regulatory authority has laid down the minimum standard. The maximum standard of Harvard Medical School. Okay, so there is nothing, sky is the limit. So when you go to a doctor, for example, you are a patient, you go to a doctor, you want the best of the doctors. When you go to school, you want your child to get a best school. When you go to Supreme Court, High Court, you get a best lawyer. Best in the quality of the knowledge, skill, and also human values. So if you have to deliver a good medical doctor, he has to have good medical education, skilled so far the professionalism is concerned, he should be holistic approach for the society, and he should be ethical. So when a person come to hospital, he expects a doctor like a god who should have a knowledge, skill, ethics, and holistic approach. And he should be damn cheap so that average poor man from a village can get the best treatment, which doesn't happen. Now come to education. We have two parts of our education: educating our student and educating our society. We all know in pandemic period, we have educated very fast. The vaccine which takes 2 to 5 years is going to be prepared within 10 to 18, 10 months to 1 year. So we have high speed the education and high speed the research. The number of paper published in COVID in last 8 months is more than 5,000, which would never happen in any topic in a year anywhere in the world. So we are definitely rechange our thinking process. We have tuned our brain to the management of COVID patients. We have tuned ourselves to digital technology. We have also tuned ourselves to teach the student online education. The lockdown started on 23rd of March. On 29th of March, we started our online education. Our all online exams went on time. Our students were doing practical examination here, and the teachers, the experts were sitting in their respective colleges and asking questions. But if you ask, is that the best method of teaching a medical graduate? Absolutely no. Because you cannot teach an operation online. You cannot show a patient online. That can be okay for digital technology. So it is a very good option or alternative in a pandemic. But if you want the best quality of doctor produced in a pandemic area on online education, that is answer is no. So I would say India has done well by adapting to the new technology to teach the students so that their education doesn't suffer. We have also seen our students do not suffer because if the exams are not conducted, they will be junior. More importantly, that 50,000 doctors, those who passed exit exam, when they come to the market, you will be having 50,000 more doctors working for the people. So it is very, very important to understand the education, learning, skill, and exam has to go simultaneously. Because even though we cannot give a very high quality education, whatever quality education you give at this pandemic area, it will be very, 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 very helpful for the suffering society. So if you want overall, we have done teaching, we have done research, publishing a lot of paper. Myself has written about 8 papers in this period, and we have adjusted and doing in my hospital, we are doing co-vaccine trial, and we have also have testing both rapid test and RT-PCR from March. It started in the pandemic started in March in India, rapid, and we are doing
Okay.
the molecular diagnostic test because our lab is enable accreditation. So our students have adjusted our situation. Our doctors are adjusted mentally, physically, social to pandemic, and I think India has done well. Medical education service, teaching the public about mask. How you see that how quickly people adjust to mask, social distancing. I can
Yeah.
assure you that a state like Odisha, 95% people are abide by the law, so that we can keep the pandemic control. So we are
Yeah.
educate the people, we educate the teachers, we educate the student, and we have delivered the service in an optimal way. I will not promise that we have done the best treatment because we are in a very hardship situation, and we treated our OPD and operation theater never closed. So we simultaneously work for COVID and non-COVID patient, realizing the COVID is not the only disease in the world. We have to treat the rest of the disease which was existing before COVID. So I think it's a very challenging for all of us, and especially for the people those who managing COVID wards, and education has becoming challenging. But given the infrastructure and situation, we have done optimally well. We have not done very superbly, but because you cannot tell that, we could have done better if we had a better infrastructure and better manpower. Because we are struggling with number of doctors in India, it is only 40% of required strength we have. Thank you very much.
Thank you very much, Dr. Mahapatra, for taking us through the overall scenario. We are glad to know that your university is also has taken up the co-vaccine trials, and you also mentioned about the standardization of medical education and medical healthcare services so that it reaches out to the poorest of poor. So there is, you also talked about the ethics, which is very important. And as you mentioned, there would be no replacement for the physical teaching with the technology. Of course, there should be a blended learning.
Thank
Now,
you.
we would like to take the perspective of yet another physician and also educationist, Dr. P. Balakrishna Shetty, who's the Vice Chancellor. Dr. Balakrishna, uh, what would be your perspective in this COVID era? What needs to be done in this medical education going forward so that things can be done, dealt with efficiently in the future challenges?
Yes, our speaker has told very well about the education and evaluation. As far the education is considered, yes, all these universities are doing online education. Okay, so from the date these lockdown was announced, everybody has started. Of course, we started on 24th of March. But online education, of course, it is a very good thing that we are doing online education. But we have seen a lot of problems with the online education. You know, there are chances that students will log on for the online class, and after that, we don't know who is listening to that online class, whether the student or their parents or their friends, or whether it is just goes on as an online class, and I don't know who will be in front of this online class. So that was the biggest challenge we faced with these online classes. So online classes, of course, everybody talks about online classes, but the question was, then we faced this challenge when we wanted to organize the examination. When we wanted to organize examination, that time the students came, sir, all these online classes, we have not understood anything about the online classes. You know, that was a time when we realized the difficulties or the deficiencies or the problems of online classes. So within a month, we started another innovative method of online classes, that is called a Z2A technology, or answer first and discuss next. It is also called a grasp technology. So what we did, we told our students to read about a particular subject. For example, if it is a first year student who is talking about who is studying the cardiovascular system, or I would say basically I would say who is reading about the heart, we'll ask all the students of the class to read about the heart. Okay. And after they read about the class, because in medicine I don't say there is such a rocket science to teach. Of course we need to teach, students should understand something, but it is not like mathematics or calculus or something define, or all those things are not there in the medical field. Of course they need to understand the medicine. So we said you read about a particular subject, number one, and the next day morning when we start the classes, we used to ask them 10 questions at the beginning of the class itself. So the first 5 minutes will be spent on asking questions. So the faculty members will throw 10 questions on their PowerPoint, and either the student will write the answer immediately, or we will then start taking the class for the next 40 minutes. Then at the end of the 45 to 50 minutes, we will see the answers of the students. It can be seen in any chat box. We have got a very good software, and just like about 150 medical students can send answers for 10 questions in the MCQ format. That they say it is A, B, B, C, C, D, D. For 10 questions that are marked either A or B or C or D or E, something like that. So with that thing, we started what is called the assessment. Okay. There is one is education, second is evaluation. Okay. So before the evaluation, every faculty member should know what is assessment. Assessment is done on day-to-day basis. Evaluation is done maybe at the end of the semester or at the end of the year or something like that. Is called examination or university examination or evaluation. But what is more important during this pandemic, during this online classrooms, is assessment. You need to assess your students on a day-to-day basis. That is done only when you ask them to read and ask them to answer for those questions in the classrooms. And this has become, I think I have given this lecture everywhere, and we say answer first and discuss next methodology has become very, very popular in most of our colleges as well as in Karnataka. So even today morning I gave a webinar and I told there is no point in taking one-way classes for our medical students. It should be answer first, it should be discussed next. The second thing what we did is what is called as the integration of all these our medical subjects. Basically, let us say when somebody teaches that there is anatomy. Anatomy means the structure of the body. Physiology means function of the body. Biochemistry means how these things are happening in the chemical level. So anatomy people will start, they'll teach anatomy of the liver, and physiology people will discuss about functioning of the brain. So what we did, we integrated. The integration is when the anatomy teacher is teaching anatomy of the brain, the physiology teacher will teach physiology of the brain, and biochemistry teacher will teach what is happening in the brain. So it is called integrated teaching. So similarly, let us say diabetes. So surgeon will talk about diabetes. Physician will talk about diabetes. Gynecologist teacher or a gynecology professor will teach about diabetes. Everybody, ophthalmology, they'll teach about diabetes. So we have made integrated diabetes teaching. So the each and every section will teach diabetes at the same time. So we have integrated our curriculum so that there is no overlapping of these particular subjects. So this is called integrated teaching. So one is answer first and discuss next. Second is integrated teaching. And the third thing, actually, when because of Corona, I was the happiest person, because we, the teachers, had put our students within 4 concrete halls, and we made them to listen to our boring lectures. And the students, the 101 PowerPoint lines in the PowerPoint presentation, the same old presentation our faculty members are doing. I'm not against our faculty members, but these things were happening. But now I would like to say our students have become more independent. They have become autonomous. It is not necessary that a student should listen to only Dr. Shetty's radiology class. My student has become independent to listen to any class in the globe. He may be listening to a class from Harvard University or a Stanford University, for any university for that matter. So our students are now able to listen to any lectures. The Google or internet, they have become the best teachers, or the more important teachers than the teachers in the universities. Okay, that is the one thing which has happened. But I would like to say our faculty members should not feel apprehension. They should not have an apprehension. They should not have a fear of losing their job. All such things are not important. We talk about artificial intelligence, and we say all the radiology images and the reports will be given by the artificial intelligence. That doesn't mean that the radiologist should be scared of artificial intelligence. So because of all these online teaching programs, our faculty members should not be scared, because it is going to stay, and we should know that teachers should be aware of all these programs. So that is one teaching. And the basic thing I would like to tell to all our academicians, that this is called the Corona year. From this March, maybe for the next February, we may have this Corona year. Don't consider this. People wanted to consider this a zero financial year, zero business year. Possible. Okay, no problem. But this year should not be a zero academic year. You can say it is a latent academic year, where we will like to teach them, and we would like to make them good students. So it is not a zero academic year, it is a latent academic year. It is our responsibility, is our moral duty to see that students will learn from us. Now, coming to the clinical exposure to the students, that was the greatest challenge. How to give the clinical exposure to our students? Of course, there are so many softwares where anatomy can be taught as a software, and you can also say clinical scenarios you can give, but it is nothing. It will not replace a personal examination of a student. So what we have decided in the university is, this particular year we will take only classes: anatomy, physiology, biochemistry, pathology, pharmacology, microbiology. All classrooms will happen this particular year, and by the grace of God, we feel the Corona will settle down. Then all our students will come to our universities. Then will expose them to the practical training. So that is the one methodology which we have followed. Now, coming to the what is the evaluation process. So I will tell you a very beautiful example. What are the challenges we are facing as far as the evaluation process is considered. Due to COVID crisis, there are almost 80% of the students went outside the hostel, so they are staying outside the campus. But there are about 20% of the students who are still within the campus. So when we wanted to do an online examination, of course, those who are outside the campus, definitely they were allowed to write online. But those inside the campus, those inside the hostel, we told them to come to the examination hall and write the examination. So that time we really faced a challenge. And those students who are staying in the hostel, they said, sir, we will not come to the examination room. We will write our exams from the hostel only. We said, you are in the campus only. Why can't you come to the exam hall? So, but they were refusing. They're so reluctant. They're resisting so much. Sir, we will not come to examination hall. We will write the exams from our hostel rooms. So that is a time we understood what a student likes to do. He wants to have an open book examination. He wants to write an online examination so that he can see the book, he can copy, whatever it is. There are 101 reasons which I don't want to highlight because the time here. So what you can do at that time is not to the evaluation process or examination process should be little different. It should not be like main question, short note, all like that. It should be a case-based question, so that a student, even if he opens a book, he will not find a direct answer for that. It should be a patient comes with a fever, like this, like this, like this, like this, like give a case scenario, and what are the causes of this particular condition, and how do you diagnose, like that. So it is a case-based scenario. So evaluation is not direct; it was an indirect evaluation. So these are the two things which we did. And finally, the last thing is about the copying a lot of these things from the foreign universities. Somehow I am totally against these foreign universities. Of course, there are so many big media statements that Indian universities are not in a top 100 and all such things. The moment India become a global hub for education, these Western media started criticizing our universities, telling that Indian universities are not good, their doctors are unemployable, their engineers are not employable. All such things came out into action because and these Western countries were afraid of India becoming a global hub in education. So that is the most important point out. Of course, Harvard, Stanford, everything is good, but look at the crisis, COVID crisis. If such a crisis was there in India, how much these countries would have made fun of India. Okay, they said they would have told so many things against India. But look at these five major countries: US, UK, Germany, Italy, France, everybody. Not in thousands, there are lakhs of people are getting infection, lakhs of people are dying there. Of course, we also having the death rates. I'm not denying that, but our fatality rates are very less. But when people are dying in front of them, look at what Harvard is doing, what Stanford is doing. Where is the research? Where is the medicine? They said remdesivir, give this antiviral. Now it is useless. Where is this Mayo Clinic? Where is this? I just want to find out what research they used to do. They used to say Indian universities are not good for research. What happened to their research? Their people are dying in front of them. They're not able to give any solution. So what I'm going to tell you is our universities are good. Our students are good. We are much better than them. It is not that we need to copy everything from the West. We not see West or East. We are the best. So we need to follow our own protocols. We talk about vaccines. What vaccines? How whether vaccines can help us? There was a rat race to create a vaccine. None of the vaccines have helped anybody. So it is not the question of vaccine. We know about influenza, we know about flu, we know about so many things, and there are vaccines, but these vaccines are totally useless. Not even 5% of the people take influenza vaccine. So it is not the question of vaccine. As far as the Indian students are considered, I would like to make my student very strong. My students should be strong. My people should be strong, and we should take care of our students. It is not that we just give lectures. We are good. We are very good in giving lectures. They say Indians have got a diary of giving lectures and a serious constipation of implementing these things. So we need to see that our students are good, our students are strong, our universities are strong. We need to give autonomy to our students so that they do very well in their examination. Not only in the examination, they become good doctors to help our country. Thank you very much. That is what I would like to say.
Thank you very much, Dr. P. Balakrishnan. You have overall took right from you have given the comprehensive approach towards the teaching methodology, at the same time assessment, and you also talked about various progress in uh, the COVID vaccine that is happening. Of course, India is the best, and we did our best. Our healthcare professional on the forefront are doing best. So now we have heard from the academic experts who are heading the medical institution. Now I would like to call upon Mr. Arpan Stephen, uh, who is the e-learning expert from Bahrain, UAE, from the Arabian Gulf University. Mr. Arpan, can you listen to me? Am I audible to you? Mr. Arpan? Looks like there is some technical hitch. He was available a while ago. Mr. Arpan, can you, are you audible? Can you hear us? As Dr. Preeti, are we audible?
Yes.
Yes, Dr. Preeti. We would like to have your initial remarks on uh, your perspective towards the medical education in this COVID era. What
Okay.
has, yeah.
Okay. Good evening and thank you. I think what I would like to focus on is we've been able to listen to different panel members who have shared about their experience of teaching over the last 8 months. I think what I would like to share is probably just dwell a little bit on the disruption the whole COVID scenario has caused on our daily life, on education. And in innovation, there is a concept called as disruptive innovation. It completely changes the way you think. And I feel that's exactly what has happened. Several things which we used to probably fight against, we've had to accept it, perhaps even at policy level. For example, whether it is telemedicine, it kind of immediately got passed. It was used. The uptake of it has really ramped up. So there is definitely the connection between technology and probably medical education or any education. So edutech is a very common word, and that's probably here to stay. It certainly will not be 100% over time, but in many different ways, technology is required to be a part of how we teach. The other perspective I would like to give is, the purpose of medical education is, of course, to develop competent doctors. And we all want to scale up the standard so that we are, focusing on what we call as the competencies, because we do not want at one end a graduate who is just pass. We would like every person who has earned that degree to be proficient and competent to the necessity. But at the same time, it is very important that they are not only competent, but they also need to have ingrained within their DNA during those years of education the whole ethos of innovation, the amount of innovation that is happening. How do we now capture it and teach it? For example, Professor Mohapatra referred to that, this increase in research papers. And so it must need to take place. Yet at the same time, we do not want research waste. In the sense there is whole paperwork which is produced, but it is published, but perhaps not of so much great value. So there also, just like we would like better, competent graduates to come out, we would like to increase better quality research. So along with that, I really feel that we have an opportunity to really ramp up on the innovation front. For example, our students, how can they really increase in the application of patent? We need local innovations which are useful in our context. So just as much as we apply our thinking to think about research, creation of knowledge in a very structured, systematic way, we need to really see how do we in our education system incorporate so that all these students come out with, on one side, competency, but they also think about how they can improve the quality of healthcare. And one perspective required will be for them to think not just jugaad, but proper innovation, which can become mainstream. And to this extent, we see there are a lot of hackathons happening. There are a lot of competitions which look for new ideas. And these need to be encouraged, because definitely our students who get in, at the end of the day, the 80,000 students who get in, out of that, probably something like 16 lakh which had applied for NEET this year, they're definitely what we call as a better quality students. So how do we really encourage them to think out of the box, encourage them to continue to be creative? And I think that opportunity we should not miss. The other point I would like to say is we have seen during this last 8 months or so, there's a whole lot of conversations about resilient systems. It could be about resilient health systems. It could be about resilient communities, or at an individual level, as an individual, just having the agility, the flexibility to deal with the amount of change that was thrown to us. How do we now teach all this? We, of course, teach about disaster preparedness. It's become probably part of the curriculum. But then how do we also, in our curriculum, instill factors like this? And how do we also, as a part of the curriculum, we really need to think through of, how much do we incorporate this whole digitization? Because on one side, when we look at the hospital, they are talking about, okay, medical records, electronic medical records, and now they're talking about electronic health records. So let us say if that is going to take place, that means the way that we need to learn needs to be something different. And as the other panelists also alluded to, the whole teaching of practical and clinical was so difficult because we just, we're not there. The equipments are somewhere else. It's not something we can take home. Theory, yes, the knowledge may be in our brain, in some PowerPoints, in some books we could access. But how do we deal with this? So if telemedicine is there, simulation is increasing, what is the balance that we need to strive at? Because we will not go back to a zero level. But what is that optimum? And perhaps it is another set of research or something that will show us what is that balance between having a certain amount of the technology, even for our clinical teaching. For example, we did an experiment just to ask our students to come up with what kind of apps are there. And we were amazed at the number of apps which exist. So several equipments are probably there as an app. So it is there in the smartphone. So we are able to make the students apply it. So I think we need to look at this whole concept of truly being more multidisciplinary again. Our education after 12th is pretty much in one sense silo, so if you are into medicine, then it's only with medicine that you deal with. So you enter into engineering, it is with that. But I think we are trying over the years to kind of see, since we work with so many other healthcare professionals. For example, on September 15th, when the National Commission for Allied and Healthcare Professionals bill was introduced, they're talking about almost 65 different groups, so 65 different occupations clubbed under broad 10 categories. Now, all these groups need to work together. How much of it do we teach within our education system? How much of it is what I would say a structured teaching rather than, yes, during residency, they do, of course, get exposed to. But what is the appreciation and how much of that teamwork, how can we from the education sector focus? So to kind of sum up, I would say, how do we integrate innovation, responsible innovation, which is ethical, definitely.
Yeah.
Second, how do we incorporate this whole concept of resiliency? Third, how do we incorporate this whole part of multidisciplinary teaching and learning? And whether we like it or not, there is a whole another spectrum which is taking forward artificial intelligence, etc. So how do we really make sure our students are ready for the tomorrow, which industry is kind of creating? So I think that's the challenge, and we have right now a big opportunity. So many experiments are going on to kind of integrate. And these are my thoughts at this point. Thank you.
Thank you very much, Dr. Preeti. You absolutely rightly said that how do we capture these innovations, this resilience that we could come up with because of the pandemic? How do we integrate all of them is the biggest question. Of course, technology is there. How we include it in our policies, in our education policies, a lot needs to be done. And what are the infrastructure that also needs to be upgraded accordingly? That is the question. With this, as Dr. Preeti has talked about the innovation and disruption, I would like to come to Mr. Arpan Stephen. You are a e-learning expert. Would you like to tell us that now we have also come across called edutech and digital healthcare? Do you think what is your say on inclusion and integration of digital healthcare in the medical education or curriculum?
Perfect. Hi, everybody, all. I hope you're able to hear me, right?
Yes,
Okay,
you're
great.
loud and clear.
Yes, sorry, I had to go in and out. We had a situation here, but I'm happy that I'm back. Okay, I'll speak more on point of e-learning at this point in time related to how we've been able to cope up and what suggestions we've had. And what challenges we had as a medical university, as a regional medical university. Just to give you a brief, I work for Raven Gulf University, which is the only regional university that was formed and is governed by all the 6 GCC countries. It's funded and managed by the GCC countries. So we have students coming all over from all of the 6 GCC countries as sponsored students by the government. So when the pandemic, the COVID-19 pandemic, hit us, it basically forced us to design new approaches to both classroom and clinical learning. And there were many challenges, basically. And to answer the question, probably what I speak will answer the question for your question as well. The biggest challenge right now that we had was, to socially isolate and socially distant the students, which practically is very challenging, especially in a medical school, where in clerkship rotations or in clinical rotations or clerkship, or for that matter, even community medicine for phase 2 programs, where hospital visits and training is important, it's kind of very difficult. So just as everybody, was mentioning, by the use of the technology that's available online, by the help of Zoom, by the help of WebEx, by something what we call Big Blue Button on Moodle, we also approach that whole measure. Now, there's something that I really wanted to point out at this stage, what we paid more attention in, and something that we should pay, that I would suggest everybody to pay attention is, like when the pandemic hit us, everybody went on to audio, video, digital media. And everybody started taking sessions on Zoom. Everybody started taking sessions on WebEx. One thing that many people forgot is the evidence of education that's done. And trust me, when the time comes, when we finish this era of COVID, people are going to ask about giving you evidence of every activity that was taken. Okay, so our whole model of our using technology in terms of in medical education was based out of evidence. Do we have evidence of every activity that has been taken, that has been done? So every activity anyway was remote learning initially, and now since especially in Bahrain, it's only 200 or 300 cases every day. It's come down. So we've started in-campus session for our clerkship phase for year 5 and 6. But again, they're all following the COVID protocol. And even for our community medicine phase for year 2, 3, and 4, family medicine, public health, maternal health, antenatal, postnatal, and so on. we have something very interesting. Main challenge was not, we actually follow a problem-based approach. So we don't have lecture-based teaching. We have problem-based teaching that happens. Okay, so for us, for phase 1 and phase 2, which ends at year 4, remote classes were okay. But when it came for clinical teaching, where they require skills, we have something called as what we integrated called as DXR, which helps and aids in building clinical acumen by simulating patients with the help of AI. And I think this is where the digital healthcare can really, it's going to be an integral part. When we talk about digital healthcare, not just in education, we talk about telemedicine, we talk about apps that make use of AI and so on. And we have found this really, really helpful in teaching, because DXR, it's something from US. I'm sure many of you would be aware of this, but it uses AI to simulate a real hospital environment where students are introduced to different patients with different medical conditions. And then based on the questions that you ask, based on whatever with the help of AI, you know, the system will respond as a simulated patient, and then you go on giving your diagnosis and things. Okay, one more thing I wanted to talk about is I think it's good. I think AI can play a very important role in medical education, especially in digital healthcare, for a simple reason. Now, especially even when the COVID situation is over, here, especially in the Middle East, there are new things that are coming up, which is called mobile consultations. People are being restricted not to go to hospitals unless very necessary. So especially where the government here provides, even for the expatriates, the government here provides healthcare facilities free of cost or at a very limited charge. For specifically, let's say, if you have diabetes, or you have hypertension, something that requires continuous medication, people don't have to go to hospitals anymore. There have been apps that have been designed where you just register. You just need to submit your blood reports. Your doctors will assign your medicines, and the medicine will be dropped at your door place. You don't have to go anywhere; it will be dropped. So I think this is part of the digital healthcare, based on which everything is worked on mobile applications, and I think this is going to go forward way, because people want the medical facilities to be available at any given point in time, wherever they are and whenever, without having to go to hospitals. So I think it's a good step. I really believe that COVID has done wonders in terms of realizing how digitization in education can really benefit education thing. One huge case I can give you, which really benefited us, our resource lectures are optional, okay? So we are not marked attendance on resource lectures. So it's open, whether you want to attend it or you don't want to attend it, it's completely up to you. And we've seen a growth in 50%. So now, because the sessions are online, there's a 50% increase in the participation of students, because they can sit and do it at their own pace. One thing that I would like to, last thing that I would like to also point it out is something very interesting what everybody was talking about is the assessment part of it. And 2 months back, I was speaking at a WHO Collaborative Center seminar that was organized by the WHO Collaborative Center in the Middle East. And the topic that I spoke on was on the assessment part of it. Successfully, we have been able to assess students both at written exams using high fidelity proctoring solution called ExamSoft, which helped us in giving written exams. So just to update everybody who's seeing, like literally when you're taking an exam, it's in a very secure environment. the whole screen is locked out for you. It records everything, and by the help of AI, it will actually go ahead and proctor your exam. So there's no cheating attempt whatsoever. And the system will identify in case there's any cheating attempt, like moving heads, moving hair, looking. If there's any device, by the help of AI, it will actually mark those pointers to show you if there was any cheating attempt and so on. And then we were able to even do the clinical exams, our OSCEs and our OSPs using the breakout room facility, wherein we had about 50 faculty, not just our own faculty, but doctors from different institutions who were the examiners using the breakout rooms, and successful. And I'm very happy to share that we actually graduated 160 students as medical doctors with our medical program. So I think I would completely agree to everyone who was talking about the assessment part, of which we have learned a lot from this pandemic, and I'm sure it will continue the same way. Thank you.
Thank you, Arpan, for sharing your thoughts. And you also talked about, of course, here Dr. Preeti mentioned, Mr. Arpan also mentioned about the innovation, artificial intelligence, and also, of course, in the beginning, Dr. Rajiv also mentioned about the use of technology. And later, Mr. Balakrishnan and also Mr. Mahapatra mentioned about the assessment. It cannot replace, of course, the technology cannot replace. There is the integration that is required. Now, before we close this session, I would like to open this floor for a cross discussion. Mr. Mahapatra, you also mentioned about the clinical trials in your institution. Now we also talk about the integration of the technology, and also of course the emerging technologies like artificial intelligence. And I would like to know, how can this integration and the blending of these clinical studies and this artificial intelligence can come together? You're also the vice chancellor of this university. What do you briefly can you tell us? What would be the way forward?
I think I think you have to optimize the use of digital technology. Many times I have attended the digital technology conference in the world, how the ICT has helped the medical science and HL7 and other technology. I went to the Tokyo and other universities, Strasbourg University, how the digital technology has improved the knowledge, skill, and virtual work. Because if you have to give a skill, let us say, as a neurosurgeon, I have to teach somebody of brain tumor operation. I cannot do it like that. So you have to do virtual. So many things has gone. And what is more important, the government of India has given a lot of stress to telemedicine. And when I was in Sanjay Gandhi, we spent National Telemedicine Center and Sanjay Gandhi at a cost of 50 crores. And we were giving, because what is necessary, it is not doctor's job. You have to have backup with good technician, good digital platform, good quality images, and many things which it is not artificial. Let us say a middle of a night a stroke patient comes. I have to decide whether he needs an operation or not. It is on your intelligence. And when you apply the artificial intelligence, my friends abroad say they don't do anything. If the artificial intelligence operate, they will operate. But if the patient is dead, patient is not going to make it. Like that, we are giving plasma therapy, the person is dying. But the entire world is telling plasma therapy is useless when the patient is breathing last. It has to be given to serious patient who is not in ventilator. But in India, what we are doing, because of constraint, because of lack of plasma, we are giving plasma person just before dying. That is how all over the world plasma has not worked. Plasma therapy has not worked. Now the artificial intelligence will not tell you, definitely many places, nothing is 100%, believe or not. If the human brain computer fails, artificial intelligence cannot give 100%. If my judgment become 80% correct, you can add another 8 to 10% or 15%, because nothing is 100%. So, but if you ask me, what is the role of digital technology in medical science? We have a tremendous role. We have sort of doctors, we have sort of quality teachers. So if you have a tele-education, tele-consultation, tele skill development, At AIMS Delhi, when I was the HOD, we spent 10 crores rupees for a simulation lab because I had gone to Tokyo University to see the simulation lab. And if you happen to see the website, Strasbourg University has spent $2 billion called Wave Search. They created by the finance of the France, South Korea, and Brazil. And they teach every year the virtual teaching that like that you have to do a laparoscopy. The laparoscopy has to be in a cadaver or in an animal, which is done by the simulation or by the dummy, or in a case of mannequin. So question is that large number of skill developed in medical professionals can be done by digital technology. So if you say how much digital, how much physical technology, then you understand somewhere you have to optimal. Believe or not, out of 500 medical colleges, about 30% medical college do not have CT and MRI. The MCI was promised by the principal who promised that I will get MRI. They won't have money for MRI. When in 2010 to 2018, 10,000 medical seats were de-recognized, the maximum radiological equipment in a medical college was a X-ray machine, digital X-ray. They did not have ultrasound, they did not have CT, they did not have MRI. What's about PET scan and SPECT scan? So we are not talking about ground reality. We are talking about technology versus non-technology. Both are required because we cannot say we are poor and we have third-rate education. We cannot say we are superb and we have got PET scan, SPECT scan, gamma camera everywhere. So we have to have a blending of optimal requirement. That is why it is very difficult to decide in a medical education what are the optimal equipments you require for a medical college. A cost of the medical college is 250 crores. A cost of engineering college is 10 crores. When I was in AIMS, we understood a medical graduate of AIMS New Delhi cost 10 crore to the government of India, 10 crores. So you are graduating a medical student from AIMS at a 10 crores. Can every institute, every medical college do it? No. So there is a quality at the cost. You cannot tell I will not spend money and with best quality. So we have to have manpower, infrastructure, then quality. When you talk about top class digital quality, a, a digital operation theater can cost somewhere between 10 to 15 crores. A modular OT can cost between 50 lakhs to 3 crores. So question is, you want a digital operation theater? You want a digital lecture theater? You have a digital skill development lab? What we are talking about? I spent 10 crores DST money for a simulator lab in animal experiment at AIMS, but that is not the standard of protocol. I cannot tell standard protocol is AIMS or standard protocol is nothing. So we have to optimize between the non technology and non-technology so that our students get a optimal quality education. It is best to have a optimal quality education so that, see, 90% medical graduate of AIMS go to US because they think they don't have facility outside. So if you get an MBBS from AIMS, go to periphery, nothing, then you get depressed. Say, what do I do? My education has gone west. So this impression should not be given to medical students that I was trained in a very good institute with all facility, and when you go to periphery to district hospital, there is nothing, not even a computer. So the question is that we have to optimize.
Yeah, you're
Thank you very much.
absolutely right, Professor Mahapatra, that it is the technology needs to be used as a tool for a better delivery of health services. It's not, it shouldn't be a technology versus non-technology. It should be an optimization, as you rightly pointed out. It's about also about the funding of these labs and equipments. Dr. Rajiv Yeravdekar, we would like to have a parting remarks from you. You mentioned about the technology in your institute, Symbiosis International University. We would like to know how you are taking it forward in the medical education. Can you please unmute your phone, Mike?
Okay, we've got a Symbiosis Institute of Technology and Engineering College. Now when we say deployment of technology, it is technology beyond the engineering aspects. So we've got the Faculty of Media and Communication. And just to put it very simplistically, a couple of months back, I had an interaction with our faculty, Dean of the Faculty of Media and Communication. And she conducted a workshop for all our healthcare professionals just to be camera ready. Because we healthcare professionals are not taught to be camera ready. We may be excellent subject experts, but how do we project ourselves? How do we convey ideas? How do we ensure learning outcomes, as Professor rightly mentioned, is something which we are not taught. We need to be understanding different modalities of deployment of technology. Gamification is an emerging trend. Edutainment is an emerging trend. How do we engage with technology to provide all these for a wholesome learning experience for the teacher to the student? At the same time, preventing a burnout amongst the faculty, that is so critical, because today, as Dr. Professor Mohapatra very rightly said, hospitals don't treat patients. It's the doctors within the hospital which teach patients, which
Yeah.
treat patients. Similarly, medical colleges do not train the doctors to be. It is the teachers and the faculty, and whether it's the AIMS or the regional medical colleges or any other institute, academic institute, the core and the software is the faculty, and that becomes the, so as to say, the faculty are the showstoppers as regards the delivery of healthcare or academic delivery is concerned. And fortunately, given the multidisciplinarity at Symbiosis, it is not only the healthcare professionals, but the faculty from the media and communication, engineering, geoinformatics, a lesser known discipline like geoinformatics is helping us in our health demographic surveillance system by helping us map out the community which we have adopted as a part of our Symbiosis community outreach program and extension. So what I want to get to the table is that we need to get, as healthcare providers and as healthcare educationists or medical educationists, we need to get out of our ivory towers. We need to get out of our silos. Unfortunately, we are all trained as healthcare professionals to work in our own silos and ivory towers. The time is come to engage with what we call as the 21st century skill sets of transdisciplinarity, adaptive agility, synergistic collaboration, and time has come to symbiosis, integrate, amalgamate knowledge, expertise, and experience of fellow professionals beyond healthcare, beyond medicine, to embrace other disciplines. Because a healthcare communication guy would be better able to tell you how to communicate and disseminate a particular message, because we are simply not formally trained how to talk. And therefore, we came up with different versions. Smoking is dangerous to health. Smoking can cause cancer. And today we say smoking causes death. And that's the shock impact which has resulted in a dramatic decline in the consumption of tobacco and products.
Yeah.
So we need to understand the supremacy of other stakeholders in efficient delivery of healthcare services as well as healthcare education beyond medical nursing education alone.
So thank you, Dr. Raju. Dr. Raju has mentioned integration, collaboration, and innovation is the key. Dr. Balakrishna, your take, your parting remarks. Could you please unmute your mic, Dr. Balakrishna?
Yes, of course. I definitely say technology is very important, but technology is not the be all and end all of healthcare medicine. Okay, there is a lot of involvement by the vendors in this field of technology. They say, for example, if you talk about CT scan, they'll say you should have 64 slices, 258 slices, all such slice wars. But basically, a 16 slice CT scan do much more. It can do it can see everything. But there is a lot of connection. I would say there is a big mafia of these people who are providing technology. Okay,
Yeah.
that is not at all required for human Indian healthcare. We are suffering from so many other conditions like dengue, chikungunya, malaria, filaria. Our social diseases are much more important for us for a public healthcare system, and we should not focus too much on technology. Of course, I would say All India Institute of Medical Science should have all these technology. But all these private hospitals, small hospitals, government hospitals, we don't have technology. We can take care of 99.9% of patients without a CT scan. That is the most important point I would like to say. Technology, you should not force technology into healthcare. It is required. I am a radiologist. I know what is technology. I know what is CT scan. I know what is MRI. But healthcare is not technology. It is giving the love, compassion, and affection for our patients. That is more important.
Absolutely right, Dr. Balakrishnan. It cannot replace, and if you focused on, you're stressed on the basic healthcare service that needs to be provided. I would like to come to Dr. Preeti for the parting remarks on these particular points.
Okay, so I think I'd just like to add a few more points. So, one, currently, specifically, we do need skills related to social media. How do we use social media? How do we use it for learning? And most importantly, how do we manage it? So, that's also how do we incorporate that into the curriculum somewhere. The other is, I think, as a doctor works, they interact for a variety of reasons besides the patient, family members, and all. When you think about it from the industry people, for example, Dr. Balashetty just remarked about technology. So it is very correct. How do we know what is an appropriate technology
Yeah.
versus what is not appropriate? But we are constantly, whether we go for a medical conference or anything, we're constantly told
Yes.
about different technology. So how do we decide what is necessary and what is not? So, is there something about health technology assessment or some little part into the curriculum, whether it is about pharmaceuticals, whether it is about technology, something about decision making needs to be also incorporated. The other, along with this, I would think is on the whole aspect which was mentioned, we always look at the medical professional as one of the most noble professions. So there is a whole set of attitudes that is expected of them, whether it is of empathy, concern, whatever. How do we really teach it? How do we teach attitude? And this is, there are articles on it. This is something, again, people are looking to kind of deconstruct and kind of, again, into the curriculum rather than just having role models who they observe and they learn from. So again, my last point would be that we really need to think. One part is on the medical education. We have also seen that during this phase, large number of external speakers outside our own organization, we were able to bring in experts in their area through this virtual platform, which again is something very, very important, because how do you listen to kind of like the best there is in India, and virtual platforms do allow that rather than only at conferences. So we've seen the considerable cost that training was costing or continuing education was costing, because today it happens without the refreshment and without the travel. So you brought the cost down. So that is something we are interested in taking forward. So I think we need to see how to bring in not only multidisciplinarity at the student level, but also at the faculty level, so that a better exposure is provided to the students, so that whatever they desire to do as medical professionals, they must do to improve the health system finally through, and I definitely would again add about innovation. So that's my
Thank
parting
you
thoughts. Thank
very
you.
much, Dr. Preeti Pradhan. Arpan, are you there?
Yes, I'm here. Yes.
Yeah, Arpan, would you like to give your one-pointer parting remark for this session
I think
on the collaboration and integration part? Yeah.
um, yeah, I think this actually has been a very fruitful session with everybody putting in their views and points, and I think it's a good road ahead. In terms of digital education in medical education. And I think there's a lot of learning that we have to take on and move forward. Even when COVID situation comes back, it goes away. It doesn't mean that we go back to our previous ways. Whatever we've learned so far, we have to build on it. And I think what Dr. Preeti was also mentioning about the attitude of students, I think this is a very interesting scope on how to build it. Something that I would like to just point out and give a note on my topic is first that we really need to appreciate our students as well who have gone through the whole situation along with us. It's been a tough situation for us as faculty, as administrator of institutions, but it's been a tough road for our students as well. So I think it's very important that we do give them credit of what they have been, and I think we will come out victorious from this whole situation. And I would really like to thank APAC for holding this session. I think it's encouraging. There are many things that I have learned from this, and it's really good to collaborate. Thank you.
Thank you very much, Arpan. So it is all about we got an holistic scenario of medical education, what needs to be done, what is lacking, and what would be the way forward. We talked about integration, collaboration, multidisciplinary approach, innovation, disruption. And with this, we would like to conclude this particular session, which today was the day one of second Global India Healthcare Conclave. We had an amazing session, participation from policymakers from Government of India and various state governments, including the government of Kerala, Puducherry, and many other policymakers. And tomorrow we will also be having participation from the Government of India, CEO of Medical Authority, and various other sessions are lined up, and experts who are the decision makers from various healthcare institutions. With this, I would like to thank our speaker from the state of Odisha, Dr. Ashok Kumar Mahapatra, who is a Vice Chancellor, SOA, deemed to be University Bhubaneswar, and also Dr. Raju Yeravdekar, who is a Dean Faculty Wise for Health Sciences, Symbiosis International, and our special speaker from the state of Karnataka, Dr. P. Balakrishna Shetty. He is the Vice Chancellor, Sri Siddhartha University, Dr. Preeti Pradhan from the UT Chandigarh Dean Chitkara School of Health Sciences, and our special guest from the UAE, Dr. Mr. Arpan Stephen, e-learn expert, Arabian Gulf University, Bahrain. Thank you very much, everyone, for making this session very enriching. Looking forward to connect with you once again. Thanks for joining us.